Hello everyone, I hope you're enjoying so far. We reached to the final lectures of this fourth day, and this is a special one for me. I'm happy and proud to present a compatriot, a friend of mine with whom I have shared so many great moments during our time in the university. Time has passed and Dr. André Chen is now a world-renowned oral surgeon and senior implantologist. André is a member of the Faculty of Oral Surgery and Implant Dentistry at the Lisbon University since 2004, where he got his dental degree. Dr. Chen is an official oral surgery specialist also from the Portuguese Dental Association. In the year he finished his studies, he headed to the NYU to attend the Continuing Education Oral Rehabilitation Program and finished the post-graduation in implantology directed by Dr. Dennis Tarnow at the same university. Dr. Chen has also a Master Science in Bone Regeneration and finished a clinical dental research program in 2012 at the Washington University in Seattle. My friend André Chen will present Zirconia implants meet digital revolution. I would also like to thank André for being available to share an amazing online course for the premium members of this event on digital workflow in implant dentistry. See you in a couple of hours.
Good morning to you all. Thank you for being here. For me, it's a pleasure to be here in this global event, in this global meeting. First of all, I want to thank João Borges and Rui Pereira da Costa for this wonderful job that they're doing. This is a global meeting, a free online meeting, one of a kind, incredible speakers, incredible week. So, I am from Portugal, from Lisbon, and I'm going to speak to you about a hot topic. It's about the zirconia dental implants and how this technology is no longer seen as an alternative, but has proper indications in each treatment plan. So, before I start to discussing the biology and my lecture, as I told you, I'm from Lisbon, Portugal, and I bring you a small video about my country. And before we start to go into this zirconia, let's see a little bit of Portugal. So as I told you, I don't know if for you if it's good morning, good evening, or good afternoon. It depends on each time zone that you are in. But for me here, it's good afternoon. And actually, if you see in the video, this is the Instituto de Implantologia. It's the place where I work. Actually, I'm one of those small rooms that you see over there. We have 6 floors of pure dentistry. We are over 25 dentists that work here. I mainly do oral surgery and implant dentistry, and as you can see, we are right in the middle of Lisbon. So together with these guys that you see on the picture, this is our team. And of course, this is not the work of me, but it's a teamwork. So every case that you see here as laboratory, as prosthodontists, as oral surgeons, and that's why we are a team. And this is a team that I work on my private office, and with these 2 guys that you see in the picture, also with Professor João Caramês and Helena, we formed a Lisbon team that we have also in Lisbon University. We teach at the oral surgery post-graduation program. We have a 3-year post-graduation program. And this is an overview of the Lisbon College of Dentistry, where actually Rui Pereira da Costa also teaches. So we are very proud in teaching in this institution, and whatever you want to visit Lisbon, it's an open door. You're very welcome to come by our surgery operatory rooms and our oral surgery programs to visit us. So let's jump into the team. During this 60-minute presentation, I'm going to talk about this zirconia boom. We are living in a zirconia boom. So zirconia is not regarding as an alternative nowadays, but is growing up as a therapy. And I'm going to show the pros and cons of these therapies and the indications for its use. Of course, we're going to speak about evidence-based dentistry and what's going on in the industry, but mainly this is the overview. And we've been hell of a ride since the 70s, since Brunmark launches the first steps of osseointegration and taught us what is the biology behind that. We've traveled a long way from that era. We've been in the titanium era for ages, for decades, and now we are living in a totally different world. We are living in the digital technology world. And when I speak about digital technology, you all guys think, well, digital technology, I want to be faster, I want to be making everything in 1 day, in 1 hour, in 1 minute. So speed, faster. But actually, digital dentistry didn't come for you to be faster. Digital dentistry came for you to be better. Of course, fast is a secondary outcome of digital technology because you're faster. But you have to remember that it came to help you to be better. And if you're not better with digital dentistry, then forget it. So how do we incorporate this technology in our daily basis? Very easy. First of all, you have to remind yourselves that digital dentistry is not the main core. You don't have to adapt everything that you know to digital dentistry. Actually, it's the opposite direction. We know everything about biology, or at least we know a lot about biology. We have our evidence-based dentistry. We know how implants heal. So we have to incorporate digital dentistry in our world, not the other way around. Because if you try to incorporate then to digital dentistry, you start to make some biology mistakes. And you don't want to do that. So when you speak about digital dentistry, it's incorporating that in your daily practice and not the other way around. So one of the things that digital dentistry came to help a lot is on the prosthodontic level. It means that if you have a case like this where you have a hopeless tooth, then you can quickly do an impression and transform this patient into a digital patient. And then by doing that, you start the process of prosthodontic position. In 30 minutes, you already have a provisional restoration for that patient. Of course, you can incorporate the teeth of the patient. You can do one block acrylic crown. You can do whatever you want. It means that you're faster in that way because everything is digital. So in a couple of minutes, you have everything ready for a patient to come in and do the surgery and walk out with the provisional restoration. That's what we did in this case. So in this case, it's very easy to see that Once you place the patient into our 3D software, then you can start to plan your implant. You see where your implant is going, then you translate that into a surgical guide that will guide you through the process. You can even know in which type of bone does this implant is going to be inserted in, and then you can control more your surgery. From that, you create your surgical guide depending upon the correct position of the prosthodontic tooth, and you're ready to go. So when you go to surgery, you extract your tooth, your hopeless tooth, then you insert your surgical guide and you do your drilling, and your implant, if everything goes well, will be in the perfect prosthodontic position. Now, for the prosthodontic part, this is very easy. Now, you just have to combine your biology, what you know about immediate implants, and incorporate that in your implant position. So now you have the advantage of being mechanically accurate and incorporate everything that you know from the past of immediate implants. So you know that you have to graft that buccal part, that buccal portion. You really know that you have to be very accurate in your prosthodontic position in order to hold those tissues so you don't have a lot of resorption over there. And by doing that, the patient goes from a preoperatory situation to a postoperatorial healing, and the patient doesn't notice even that he has an implant over there. The situation is so stable. So for you as a dentist, from a social standpoint of view, you have credits. And digital technology obviously helps you to be better. After osseointegration is complete and after you pass the 8 weeks, then again the prosthodontic part turns very easy, because now just to do an impression, a digital impression, send it to the lab, and the lab finish the cases. So in a few appointments, the patient has an hopeless tooth to a very stable situation like you see in the picture. And that is due not only to digital technology of planning, but digital technology to be able to guide you through this process of implant position and then for the final rehabilitation. So, why zirconia? Why going into leave titanium and start to look for alternatives? Well, the first question that you have to ask yourself is that, do we need an alternative to titanium or not, if we need one? And actually, when you look to the literature, in the past, you were not ready to listen to alternatives. Why? Because titanium was becoming big. We lived in the titanium era, and so everything was about titanium. But soon after osseointegration was discovered, and a few years later, we start to have mechanical complications. Some of the screw fracture, some of the platform fracture, there were problems, mechanical problems. Then implant companies solved it very well. They increased the stiffness of the materials, they increased the stiffness of the screw, so the platforms were different, and now the mechanical problems were no longer an issue, or at least they were a small portion of the problems. When we talk about late complication failures, then it's peri-implantitis that we have afraid. So marginal bone resorption, infection, those are the problems that we have nowadays with titanium implants. And the question is this a microgeometry, a surface problem? Does the titanium has a problem on its surface? And when you look in the literature, of course, it depends on who you read on the peri-implantitis level. It goes from an incidence from 7 to 9%, to almost 25% in the latest studies from Professor Dirks from the University of Gothenburg. So when you read these numbers, you see and you start to think that 25% of our patients will have some form of peri-implant infection. It's a huge numbers, huge numbers. So when you look at it, titanium is not behaving very well at this time, at this moment. So one of the first things that we do is that we start to look for alternatives. And when we start to look for alternatives, we ask ourselves, is the titanium the only metal to be able to have a passive layer and also integrate? And the answer is of course not. We know that titanium is not the only one. Zirconia integrates, alumina integrates, and gold integrates. So it's not the only material that also integrates. And so why does zirconia can be an alternative to titanium? And when I speak about this, I feel like I'm in the middle, or I'm in the edge, I'm in the final position of a puzzle that began in the 90s. So when the first layers of the osseointegration foundations were made, we didn't think about alternatives, but soon people start to think about alternatives, and zirconia was one of them. And the first piece of the puzzle was, does zirconia osseointegrates? And we were not ready to listen about this integration, but we know by studies of Kardaropoulos and Abrahamson that cold integrates, very beautiful histology on osseointegration level. When we speak about zirconia, it's not new. Especially here in Portugal, one of the first PhD theses done in our university from Professor Vasconcelos Tavares was about the osseointegration of zirconia and alumina implants. And what he found out is that the zirconia and the alumina implants, a study on a bigger law, they have the same osseointegration. They are able to osseointegrate. So they can be viewed as an alternative to titanium. So this was the first layers of osseointegrations that we have in our country, in Portugal and also in Europe. It's not a published article, but it's a PhD thesis. So whenever you wanted to check it, you can go to our university and see, and you check it online. So what he found out is that the alumina and zirconia had the same chances to osseointegrate it. But we were not ready to listen. We were in the titanium era, so for us that study was nothing. But nowadays it's huge. It's one of the first. So the second piece of the puzzle was, because they were trying to do a two-piece and they couldn't make it because of fractures of screws, fractures of the platform, they stayed with a one-piece implant. And the one-piece implant actually gives some biological advantage over the two pieces. And why? Because everybody knows that one of the main reasons for marginal bone loss is for us to have a micrograph. And we try to attenuate that phenomenon by doing several things. One abutment, one time, platform switching, diminish the micrograph, using conical connection. So everything that we do in a two-piece implant situation is to avoid a micrograph and to avoid marginal bone resorption. Now, because they had a one-piece implant, that is a mechanical advantage. So it's another piece of the puzzle that helps biology. The third piece of the puzzle is that zirconia implants were always regarded as an alternative, an holistic situation, something that is very unpredictable. But oh boy, has that changed, because implant companies, big implant companies like, for example, Straumann, came along. And they brought all this surface technology, all this investigation to the zirconia arena. And by doing that, they give some credibility to the zirconia issues. So nowadays you have big companies, leading companies market, selling zirconia implants, which for a social part is very important. So they brought all these microgeometry surfaces and incorporated to the zirconia implants, which gives strength to the product. So when you look at the Danny Boozer article in 1981, the mini pig, the classic, and you see all those bone-to-implant contacts, and then you compare the bone-to-implant contact that we have today in the literature on the zirconia implants, and you see that they're pretty even. Even if you compare with the SLA and some of the best titanium surface that we have on the market, not only it osseointegrates, but it also integrates with the same bone-to-implant contact percentage, which is amazing. And it started to become an alternative that is very credible. But the downside of this technology, of course, you have some literature that has 10-year data, series of cases, but the downside of the zirconia implants is, of course, if you ask me what is the survival rate after 10 years, after 15 years, my answer is I don't know. And it's a downside because it always been regarded as an alternative, and so it does not have long-term follow-ups. So if you ask me, does it work after 1 or 2 years of follow-up? The answer is yes, and with the same survival rates. But I admit it, from a long-term survival rate protocol, we still have a long way to go. So at this time, if you combine all the pieces of the puzzle, then you have a product that may be a viable alternative to what we are doing today with titanium implants. So this is about evidence. But if I ask you, are you going to buy zirconia implants and place it tomorrow on your patient? Most of you are going to say, of course not. And when I ask you why, probably it's not the biological reasons, probably it's not surface technology. Most of you are going to say that's because it's one piece implant. And if you have any mistake on the buccal lingual direction, on the mesial distals, you cannot compensate that with a prosthodontic abutment, which is an handicap. So around 2014, the last piece of the puzzle came to complete this situation, and it was the digital technology. The ability in your lab to do a surgical guide and be in total control of implant position is now a reality. So with this final piece, I think we'd have a viable alternative to the situation. So Zirconia came up in my life about 5 years ago when we decided on a canine to rehabilitate this situation with the Zirconia implant. Now, of course, this is a traditional approach to contrast with the digital approaches that I'm going to show you later on. But this is a traditional approach where we were very careful because we wanted to know that we were in the perfect position. So we did everything not to fall down in the wrong position. We have our provision ready, so we were always checking about the position. So there's nothing new with the drilling protocol, only that the implant is very photogenic. You know, when you look at it's white, when it's going in, well, we were all marvelous because it's very different from the metallic aspect of the titanium implant. But it was not that caught my eye. Well, what caught my eye actually is not the drilling protocol. Of course, that this is a standard work procedure. You do an immediate loading without occlusal contact, so be sure to read all of those excursion guides so the patient doesn't touch the provision restoration. But it was not this that caught my eye. It was after 3 months later when we received the patient for our osseointegration control that we saw that we had a stable situation. We had an incredible response from the soft tissue standpoint of view. And when I look to the picture, then I really see it that we probably have an alternative. Of course, if you ask me if it is as possible to do it with the titanium implant, of course, every day. But we are not regarding this as being better. We are seeing this under the perspective of Zirconia to be an alternative. And it's very interesting because not only is an alternative, and I think it is, but also has some features that the titanium implant doesn't have. This, for example, the soft tissue response that we're going to see later on. So we decided to go for the final restoration. At this time, this Zirconia implant catches up the digital technology, and we decided to go for an intraoral scanner instead of a traditional impression method. Now, with these intraoral scanners, you scan the patient and you transfer this information to the lab. So the lab can start to build your final restoration. So nowadays it's very accurate and it's very precise what you're sending to the lab technician, especially if you already have the emergency profile ready. So when you send it to the lab lab technician inserts that information into their softwares, and from that softwares they start to mill the final rehabilitation. So in this case, the laboratory had the canine ready for us to place, and when it comes to final placement, we can see that the soft tissue is very stable around this Zirconia implant. So here we have no longer a titanium, but a Zirconia as an alternative with the same soft tissue profiles and the same soft tissue contours, if not better, over this ceramic restoration. Now, I'm a screw retain kind of guy. I mean, I screw everything that I can. I hate to cement things. But with these one-piece implants, one of the downsides is that you have to cement your restorations. Now, if you're going to cement these restorations, be sure that you do everything that you need to do to remove those extra pieces of cement. Or otherwise, you will fall down on the literature that says that cement restoration have more biological complications. So watch out with this team when you're using this type of implants. So this is a traditional approach. So let's see how digital technology came to complete the puzzle. Well, this is a mother of a colleague of ours that lost number 21. So when we are going in for placing number 21, we see here that we did a traditional approach with an external titanium X with a GBR procedure simultaneous at the same day that we placed the implants. So everything was okay. So we did our surgery, then we did our final crowns. The patient was very happy with the situation, and she lived happily ever after with the 2 central incisors rehabilitated. Now this lady liked a lot the final work from our colleague, and she lived well for 5 years. But after 5 years, we started to have a problem. Not with the implant that we place, but with number 11. Number 11 presented with a fistula, with some chronic inflammations and complete bone loss on the buccal plate. And so at this time we were thinking, well, what are we going to do, because this has not an indication for an immediate implant placement. So my friend said, okay, let's extract the tooth and leave it healing. I do a cantilever on number 21 and we finish the case. And I said to him, listen, if I go into extract the case, the least thing that I can do is to create a pontic for you. Let me create the best pontic that I do for you to at least contour the area, and the cantilever stays on a more correct soft tissue profile. And that's what I did. I did the ice cream cone technique described by Nick Allen and Dennis Tarnow, and with that I create like an ice cream cone technique in a socket preservation kind of technique, and that was good. So after we did our socket preservation, then our friend decided, okay, so we are ready to go. Let's place the implant on number 11 and let's finish the job. And so the first thing that we did was to scan the patient. So we scanned the patient and we transformed the analogic patient into the digital patient. So the first thing that we did is that we placed in the intraoral scanner and did our scanner. As you can see, 1 year after our socket preservation, we have a beautiful pontic there. So we didn't want to destroy nothing. So this was planned to be a flapless procedure, a minimally invasive procedure using a zirconia implant. And so the first thing that we did is that we placed this information on the implant studio and start to place the correct tooth position. From the correct tooth position, we plan our implant. And this planning, we send it to the lab. The lab starts to mill our surgical guide as well as doing our provisional restoration. So of course you can do a 3D printed or you can mill your surgical guide. I have some indications for that, although I admitted that nowadays 3D printed has a better accuracy than the mill. But in this case it was a mill procedure. So in a couple of minutes you have ready a surgical guide to go in. And when you go to the surgery room, you already have everything ready. Treatment plan, surgical guide, and then you're ready to go. So you remove the provisional restoration of the patient and you try your surgical guide. As you can see, the fit of these things are almost perfect. Of course, we had to increase a little bit the technique, but nowadays everything is coming very beautiful, also because the softwares are more potent and they have better accurate. So we're going to start to do a fully guided protocol. So this is a Straumann fully guided kit. So you do the first burr, the 2.2 burr in a flapless procedure, because this was done over the previous prosthodontic treatment. So the implant is going to be placed according to the best tooth position. So from the 2.0 we go for the 2.8. For the 2.8 drilling, it's like blue, yellow, and red. It's the protocol of Straumann. Of course, if you use other companies, it's different, but each company has the surgical guide kit. So by doing this, you see that you're in complete control over the surgery. So you're now ready for placing your zirconia implant, and in a totally digital guided situation. So under the prosthodontic point of view, you see that this one-piece implant now has the ability to be corrected position. You're not depending on your free hand, but you are totally guided from planning to clinical execution. And this was actually how digital technology came to help this zirconia alternative. So you see here implant insertion and implant position. So it's always very accurate in regarding to your prosthodontic position, because implantology is prosthodontically guided. So here you have an overview of the finish of the surgery. So for the patient, this is very good. This is awesome. So from a social point of view, you now finished your surgery in a very quick manner, in a very minimally invasive situation, and the patient thanks you for that. So the patient will walk out your office like saying that nothing had happened, only a little bit of anesthesia. And that is huge social impact, and also from our clinical standpoint of view, it's awesome. So 8 weeks later, we are ready for final impression, for provisional restorations, because this was referred case, we're going to refer this to the prosthodontist again, but we are going to give the best provisional restorations possible. Now we do an intraoral scanner with a scan body on number 21 and directly on number 11. And because of the patient liked so much the final crowns that she had, we have now the ability to incorporate that photography into our 3D planning. We choose 3 dots, we merge everything together, and now we can plan the crowns in relation to what she had, and incorporating this to our treatment plan. So it's very easy now to plan the provisional restorations, press a button and send it to the milling machine. And the milling machine will mill the 2 exact crowns that we plan on the software that we're planning according to the patient's photography. We mill this, and in 20 minutes we have our provisional restorations ready. So very fast, very accurate, a secondary outcome from digital technology. But for the patient standpoint of view, it's amazing because it's very easy and it's very predictable. Now, after provisional restorations are set, this is a monolithic block. We still have a long way to go into the aesthetics, but in these situations it's very fast, and it's ready to send for the prosthodontic final rehabilitation in order to, now plan the soft tissue contour, soft tissue profiles. But for the patient standpoint, it's amazing. So let's turn the investigation mode on. So when we started to do our, we're thinking about zirconia. I come from NYU. I mean, I did my post-graduation course, this 2 years at NYU with Dennis Tarnow. And when I spent my residency there, Dennis was always very strict. He always said that what is the biological reason of that? Why is the biological sense of it? Because if things are not making sense under a biology level, then you're just showing off. It's just good cases, it's just good photography, and so on, but it's not biological pleasant case. So we stop ourselves and we follow the Dennis Tarnow rule and started thinking, what is the biology behind the zirconia? Why is it better, or why is it worse, or even if it's a biological reason behind that to be regarded as alternative to titanium? Now, together with the other members of Lisbon team, we set up 2 studies. Actually, there are the PhD studies of our thesis. The first one is Elena did it, and Elena already finished their PhD. She studied the bone response of the zirconia towards bone, or bone integration towards the zirconia implants. Well, I remain with the task of study the molecular signaling, the soft tissue response to the zirconia implants. And the reason behind that is that when you ask a friend which type of restoration, which type of abutment do you choose for your implant restoration, probably they will say zirconia. And then you said, but why zirconia? And probably the answer is because the soft tissue responds better. The soft tissue responds better. But what is the biological meaning of the soft tissue response better? Why does in these situations, when you use zirconia and completely all zirconia restorations, do we think that we have a better soft tissue? It's because of color, it's because of molecular signaling, it's because of anatomy, it's because of biological width. What makes the zirconia different? And the first thing that Elena tried to answer is, does zirconia also integrate in the same manner than the titanium? And so she did a bigger study, an animal study, where she didn't go for the bias of comparison. That was very easy. Compare the zirconia implants with the traditional machine brand mark implant. That is a bias, because you have to compare it with the best surface on the market. And Elena did it. Elena studied the zirconia implant against the OsteoSpeed from Aster surface. It's a very robust surface, considered one of the best in the market, with high bone-to-implant contact levels. So here you are, studying zirconia surface against the titanium surface. And what Elena found out is that there were no difference when she places these kind of implants and immediate extraction model. There were no difference in bone-to-implant contact. That means that the zirconia behaved in the same manner, at least in an animal model, when it comes comparing with titanium. And that was big because it corroborates the studies from Professor Vasconcelos Tavares that I show you. He also have shown that in the past, and Elena once again proved it in the present. So zirconia had not only the same osseointegration rate, but on the soft tissue level, it also behaves equally to titanium. So regarding as an alternative, titanium at least behaves, zirconia at least behaves in a similar way than titanium. So we have here an alternative that could be very interesting. Now, when you talk about soft tissue dimensions under a biological width kind of style, you're studying anatomy, and you're studying only what in a cut, what are the percentages on heights and widths of the tissue. You don't really know how the tissue is signaling against this zirconia when comparing titanium to acrylic. You don't know the biochemistry that evolved, because when you look to Blanco studies from Spain, you see beautiful histology on Bigelow, and you see the biological width dimensions from titanium to against zirconium oxide. They're pretty similar. The biological width seems to be pretty similar. So it's not the biological width component that actually does the difference. What may make the difference is how tissues interact from a living tissue situation, how they interact having zirconia or having titanium. Now, we knew when Professor Vasconcelos Tavares did his PhD thesis, this is in Portuguese, but on this PhD there's a sentence that in all of the samples, when he tried to tear the soft tissue from the implant, he couldn't do it without tearing the soft tissue. Now, there was much more than an adhesion between an adherence between the soft tissue and the zirconia, although you do not have a true adhesion because you don't have the desmosomes and don't have cement on the implant side. It was very difficult to separate those tissues. We know, of course, by the literature that already zirconia behaves better and the microbiology standpoint of view. But it's not bacteria that we are looking in. We are going to look the interleukin levels, and by doing that, I did two separate studies. One, the animal study, and the other, a randomized clinical control trial study about how does the tissue respond to three different types of material: the titanium, the acrylic, and the zirconia. And we place the implants, and in the randomly fashion way, we place a different type of healing abutment. Now, the animal studies serve us to set up, to calibrate all of these cytokines extraction reading methodology. And so when we did the animal study, the results that we found out were pretty similar. We also check if there was a bias of the microgap, and you see the CAD-CAM materials are almost as perfect as what companies do. The microgap is diminished to very low levels. You almost don't have a microgap. If you see it under the microscope standpoint of view, all these CAD-CAMs are very much alike, and they have only resembles the machine part of the implants and almost the electropolished part of the implant. They were very smooth in terms of surface geometry. Now, we went to see what happens with the interleukin 1 and 6. And why this? Because they are written in the literature as being regarded the interleukins that produce marginal bone resorption and bone problems in the long term. So when we got the results of the randomized clinical control trial, it was obvious for us. This is a study that is going to be published here. It was already accepted for publication, and I think it's going to come out in the next month. So we also confront that with marginal bone loss. So when we took the samples from these healing abutments, we see that there's already a trend. This is a randomized clinical control trial with 60 patients, and at 8 weeks, after 8 weeks of healing, we see that titanium expresses almost the double of interleukins than the zirconia and the acrylic. In other words, titanium produces much more inflammation to tissues than CAD-CAM zirconia or CAD-CAM acrylic situation. And for us, one of the reasons why you should choose titanium is mainly because of this. The way that the body is signaling is very different from titanium to zirconia. And if you look, there's a statistical significant difference after 8 weeks of osseointegration between interleukin expression on titanium and interleukin expression on zirconia. If you look, the red bar It is the titanium. If you look, the blue bar is the zirconia. If you look at 8 weeks, the bar in the middle, you see that's huge difference. So, as a resume of this article, because you can read this article later on, the zirconia expresses in the early healing less inflammation than tissues, and that could be one of the answers why zirconia behaves so good in the soft tissue situation. It means that it will express less inflammation. As consequence, you will probably have less marginal bone resorption, which in turn can lead to less problems in the future when it comes to periimplantitis. So, like Thomas Albrechtsen was saying in a couple of editorials that he did a couple of years ago, we should regard to the autoimmune response of these materials in the human body, because they may be key to understanding what happens in the marginal bone situation. But in this case, we study the interleukins, and we come to the conclusion that different materials evoke different inflammatory patterns. So that could be a thing that can affect the zirconia over the titanium. So at the end, we found out that in the bone response, there are no differences between bone response. Zirconia is equal to titanium, but in the soft tissue arena, not on the anatomy level, because the biological width seems to be the same. Elena proved that, other groups around Europe also proved that, but it's the molecular signaling between zirconia and the implants that seems to be different. So on the biochemical response, the soft tissue responds better. So we may have an alternative here, and I'm going to show a case where there's this soft tissue reaction to the zirconia. It means that we have a soft tissue discrepancy on number 21, and now we want to restore this case with an implant situation. Now, the first thing that we do again is that we place this patient under an intraoral scanner. We send this to the implant studio, and we start to build up our prosthodontic case. Now, as you can see, we have a soft tissue discrepancy here. If you place the tooth on the correct position, you have a soft tissue discrepancy. You start to plan your surgical guide, you start to plan your implant position, and then you're ready to go. So at the day of the surgery, once again, you try in your surgical guide, everything is set to go. And one of the things that we have advantage in intraoral software is that we can predict if the bone that we are placing in is good or bad, because that will affect primer stability. Of course, primer stability is not only a factor of bone, it's an equation, but to know if the bone that you're placing in, what kind of Hounsfield units it has, it's an advantage. And now you can see that if you have a very good bone or a very dense situation, probably this implant has indications. But if you see it, that is, you have a very soft bone that you probably need to bury the implant, so probably this is not the implant correct for that patient, and you have to change it. But in this case, you see that you have a very high dense bone and very good for primary stability. So it allows us to predict that our implant stability will be good, and we can do immediate loading without occlusal contact. So we did. Went to the surgery, and we did the surgery. We have a papilla saving incision because we already have some resorption on the lateral that we didn't want to increase, and we have a pallet drilling situation. It means it's not fully guided, it just guides you through the first guide, which is a major advantage. And in the second part, you will go into place your implant. Now, when you're placing your implant, you just have now to follow the drilling protocols that you did. Now we place our zirconia implants and we suture this soft tissue in a coronal position. Now, as you all know, sometimes we suture on a coronal position and the tissue just goes away. And so when we finish the case, we have a more coronally advanced soft tissue position on the implant. Now, the ability here is not on the day of the surgery, is to know if this soft tissue can hold and correct the soft tissue discrepancy that we have. And after 8 weeks, it held there. So we have a situation now that is very favorable for the prosthodontics. We have excess tissue. That's probably the situation that every prosthodontic wants, to have excess of tissue. So they start to sculpt the soft tissue and start to have a better position. But you can see that after 8 weeks, the soft tissue response, without doing nothing, is in a better position than when we started. The soft tissue response to this kind of materials is good. Once again, Is it possible to do with the titanium? Of course it is. That is not the situation here. We are regarding this again as an alternative. And as alternative, you see on the picture that it may be a good alternative. So now the prosthodontist only has to do what it does best: soft tissue profile, soft tissue contours, you know, trying in, see zeniths of the tissue and finish the job. And as you can see, you can do perfectly an implant-based restoration with the zirconia implants and still have the same outcome as a titanium implant. So it's regarded as an alternative. So you have the beginning situation and the final situation with a single-piece titanium implant. So when we talk about guided bone regeneration and zirconia, oh boy, do we have a downside in here. Because if you ask me what is the behavior of bone regeneration, regenerative therapies over the zirconia implants in the literature, then I think we have a problem because we don't have much evidence on that. So this is the case where we place a zirconia implant and we didn't have any buccal plate or any vestibular bone. So we fenestrated and now we needed to have a bone regeneration procedure. Now we're going to do here a GBR procedure. And one of the things that I think that literature has to evolve and groups have together is to study bone regeneration over zirconia implants, because we have a lot of evidence over titanium implants, but when it comes to zirconia, it's scarce. So if you ask me what is the amount of the connective tissue that we have against zirconia, I don't know. What is the percentage of vital bone that we're going to have over a GBR, over zirconia implants? I have no idea, because there are only small cases in the literature and it's not controlled cases. So I think there's a downside in here and you still have to look for. But these are the bad news. The good news is that on the clinical level, they seem to work perfectly, almost as similar as the titanium. But I agree that we have to have more evidence on that. So in this case, we did a GBR procedure and we closed it, we sutured everything up, and after a couple of weeks, we have here the healing, and after 8 weeks, the healing is completed. Now, it looks clinically, under the clinical point of view, and this is just a guess feeling, is not evidence-based dentistry, they seem to work okay. We don't have any problems, or at least we have the same problems that we have of GBRs against a titanium implant. That means that the surgical guidelines are the same, and they're mostly the same complications, you know, flap retraction, infection, so on and so on. What we don't know is if we have a percentage of resorption higher or lower when we compare both techniques. And I think that there's room there for a lot of studies to coming up, and I think they're going to come out, but at this point is a downside. So on the clinical level, you see we're ready for provisional restoration. We did our provisional restoration on this young lady, and in a couple of weeks we did the final restoration. And here's the final restoration of a zirconia dental implant with guided bone regeneration. So it seems to behave the same. It seems to follow the same pattern, but again, we need more studies on that. So when we look at all of these topics that we discussed, biology, technology, primer stability, when we combine all of these together, I think we have a viable alternative to titanium dental implants. Now, one of the things is that I'm going to show you how we incorporate our digital technology with the zirconia implants in a case from A to Z. That is not the future. This is not the past, it's the present. That's how we do things in the clinic if we're going to use a zirconia dental implant. So this is a case of a young boy that 25 years old that is going to lose the second premolar. He had an endo problem. He's had a vertical fracture of the roots. We sent it to endodontics. Endodontics said it's a vertical fracture. Nothing to do. We have to extract the tooth. So we did what we do every step. We send an intraoral scanner to the lab. The lab starts to build the surgical guide and the provisional restoration. So at the day of surgery, we are ready to go with our 3D planning and with our surgical guide. This is a pilot surgical guide, and it's not fully digital, so we just have the 2.2 burr to indicate which is the best prosthodontic position of this implant. Now, in an immediate extraction cases, I think these guides help a lot, because even if you are a very experienced surgeon, you're always blind in terms of drilling preparation. And with the digital protocol, you're always sure, or at least in the majority of time sure, at least if your planning is correct. So after the 3.3 drilling burr, we are now ready to place the implant according to the position that we plan, according to the best prosthodontic position for that patient. Now, because it's a freehand, we see the one-piece zirconia now going in an immediate extraction situation. So all very clean, all very whitey, or very photogenic, but from the soft tissue and bone response point of view, you already know, because I showed in the literature, what is going to happen to this implant. So we insert the implant according our procedure, and then we are going to place over this implant a provisional restoration. So by doing that, we have complete control from A to Z on the terms of the surgery level. So when the patient finishes the surgery, already has a provisional crown to place and ready to cement. And again, from a social standpoint of view, this is a huge advantage, because the patient will leave the office, will lift the lip line and says that, listen, I have here a good restoration in a minimally invasive procedure. Now you can see the fit from planning to fit from surgery. What you plan is what you have if you follow the correct protocol. So now you're ready to insert your provisional restoration, and the patient walks off the clinic like nothing had happened. This is a very important situation. Not only it enhances your post-op and your chances for implant survival and less infection. Now, this does not end here. So after 8 weeks of healing, the patient is ready for final rehabilitation. And how we are doing this? We are doing this by scanning intraorally the implant that we have. Now, because the softwares are much better now, it increase the accuracy and the pixel and the visibility, the lab technician really has power over these restorations, not only in terms of margin fit, but in terms of mesial or distal contact points. So everything is there. So it's a matter of just choosing the correct picture, and then we are ready to go for final rehabilitation. Now, there are two types of final rehabilitations that we can do it. One is planning the tooth and directly send it to the milling machine and have like a block of ceramic. It's called the pretile, the zirconia, the full monolithic. But with that kind of restorations, we have a problem in terms of aesthetics, because it's one block. Now, in these cases, we need aesthetic, because this is a very high demanding patient that lost, in the 25 years old, that lost the second premolar. Now, we want to have a feldspathic veneering over a zirconia framework. But in order to do that, we have to give a physical model to the ceramist. And we have now to print the models. So to print the models, we are going to use the digital technology of 3D printing. We send this information to the 3D printing machine, in this case I'm using Formlabs, to produce two separate models, so the ceramist has the possibility of placing feldspathic veneer over that zirconia crown. Now, we are going to 3D print it, not only the models, but because this is a one-piece implant, we're going to also print the abutment, the analog. So we're going to print both. We send it to the printing machine. The printing machine starts to 3D layering, and after 1 hour and a half, 2 hours, more or less, depending on the accuracy, you will have your models ready to send to the ceramist. The ceramist will pick up the model, and you will have a more accurate model than if you have a cast model. In single and multiple units, we are no longer casting the models, we are 3D printing the models. It's very easy and much more accurate. So here you have, for the ceramist, a situation where he can build a full zirconia crown over a full ceramic implant. And the situation for the patient, it's highly aesthetic from aesthetic point of view, but also on the inflammatory level, a very low inflammatory process, a very low inflammatory complex, the zirconia implant and the zirconia crown. And here you have at the final rehabilitation a very aesthetic procedure, a very aesthetic crown, and the patient goes very happy. From A to Z, it's a totally different dentistry. So there's no impressions, no castings, and from A to Z you can build a situation, an implant-supported rehabilitation in aesthetically way. So this is from A to Z. The future, well, my dear friends, the future is that patients will want a zirconia dental implant. You will now have probably in your practice patients asking you for zirconia dental implants, and in the past it was an holistic situation. Only patients that were in the meridian, in the Chinese therapies and the holistic process ask you for zirconia dental implants. But because there is a boom, not only implant marketing, implant companies and advisory and marketing situations, you have now patients entering your clinic to ask you for zirconia dental implants. And is it possible to deliver a good work? Of course it is. Of course it is. But we still have a long way to go on evidence-based dentistry. It means that you already have the products. Now we have short-term follow-ups. We have to know that if these follow-ups work in the long-term procedure. But if you ask the patient which one he prefers in terms of white zirconia or gray titanium, the majority of the patients will go for the white zirconia. And that's a fact. So you will have in your practice patients asking you for zirconia-based restorations, and now you know what to expect under the terms of biology. So the future will pass by controlling the two-piece situation, and we already did it. The two-piece situation is no longer a thing of the future, it's a thing of the present. We now have the ability to deliver a two-piece zirconia implant restoration. Now, several companies had it already in the market, but Straumann will launch probably next year the two-piece implant, zirconia implant. Now, we as a clinic had a chance to participate in the trial of this implant by placing a few in patients, and it's amazing because not only now you have the power of the zirconia implant, but you have the power to control if there's any misalignment. So there's more kind of leeway if the digital protocol is not accurate, or if you want to place it without digital protocol and then correct prosthodontic, you now can do that. In soft bone situations, now you can bury the implant, which is a big advantage. So what I'm going to show you here is not only the two-piece situation, but a little piece of technology that we are also using nowadays in the clinic. That is 3D printing the skull of the patient for implant planning and surgical preparation. What I mean by this is that in this case that you're going to see, we have a missing lateral incisor with a big concavity and a big bone defect that we want to regenerate. Now, in order to do this correctly, not only are we going to use a full digital protocol where we plan our implant according to the best prosthodontic position like I was told you, but we are going to merge the CBCT with our intraoral scanners, not only to place the implant and to start to planning the implant, but to print the skull of the patient. Now, one of the improvements of the 3Shape is that you had to do those 3 connection dots, but now 3Shape does it for you. It does the best merging. You still, if you want to do it the 3-point, you still can do it, but now it's totally integrated on the plan. Now, one of the advantages now, the ounce field units are graphically displayed. It's not just going to change your treatment plan, but it's better, it's accurate to see which kind of bone the implant is going in and what, in what position the tooth is going to have more primary stability. Now, after you plan your tooth position, after you planning your dental implant, and after you planning your surgical guide, now I will be wanting to print the skull of the patient, so me and my assistant can train in a real-life situation what is going to happen on the surgery. So in order for us to do that, we are going to import our DICOM files and transform our DICOM files into an STL file. But in order to do that, because CBCTs still don't have the accuracy that we wanted. Well, some of them have. I unfortunately don't have the state-of-the-art of CBCT I wanted, but For me to have a good STL, I still have to run it in a special software. This is a special software that we're using to print our 3D, our DICOM files. It basically, what I'm telling the software is that I'm choosing the dots from what is trabecular bone, what is cortical bone, and it dilutes that and creates the final STL. So you will create layer by layer. I will indicate to the software where is the layer, where is each layer. This takes about 1 hour to do it, and you will build the best software, the best STL. Now the good thing about that is that you only print the part that you want to use it. Now I only want to print the lateral incisor, so I'm not going to print all the skull. So I give the information to the CBC, to the software, and the software builds layer by layer my STL file, as you can see on the screen. Now, after I have the part that I want to print, I 3D printed, and I can start to play with it. I can start to play with my surgical guide, with my dental implant, and the best things is that I can sit down with my dental assistant and plan the cases like you see in the picture. Now I'm going to reproduce exactly what I'm going to do in the surgery. I'm going fully guided for a 2-piece zirconia implant. Now with my 2.8 drill, I already know this is the drill that I'm going to perforate the cortical. So it's going to be like a little jump when I'm going to do my drilling preparation on the patient. So I also can see in the different angle aspect how I'm going to the nose, if I need to reflect more the flap. So as you can see in the picture, fully digital guided situation has the complete control of the situation. And now, because you already did it once the surgery, now when you go to do the surgery, it's the second time that you're doing the surgery. So for you, you have a better control, and for the patient, it's better because you already did it once. So here you try, you know that with the last drill, you're going to completely perforate that cortical plate. And now you pick up a dummy. A dummy is like a fake implant, so you can practice. You're going to practice your primary stability, see if you have primary stability on your implant. But above all, you're seeing how the fit is working on the surgical guides and everything. So when you go to surgery, you already know what's going to happen. So after you planning, after you see what you're going to perforate on the cortical plate, after you see if everything is okay, then you go for your surgery room, your operatory room. So at the day of the surgery, you and your assistant already did the surgery once, so you're much more comfortable in what you're seeing. It's not like a surprise. So on the surgical day, you're trying just to check, even before you anesthetize the patient, just to check in if the guides are okay. So if the guides are okay, then you're ready to go. You can see that your guide is according to the plan and according to what you printed of the skull of the patient on the buccal level, but also on the occlusal level. You see where your nasal palatal is, you see everything. So everything is already planned. So when you go in, you know that your first drilling is not a problem. It will go in on native bone. It is the second drill when you're going to perforate, and you already know that because you already did the surgery. So you know that is a step here when you're going to fall down a little bit on the buccal plate, and it's about here, as you can see. Now the last drill will completely perforate it, and you already knew that because you already did the surgery. So this is an overview of the final drill, and you can compare it with your planning on the left, surgery on the right, and you see that you're going to perforate the buccal plate. So now when you're going to place your 2-piece zirconia implant, you already know the position. If you follow the guideline, if you follow your prosthodontic plan, then you just let the surgical guide your implant in. And so this is the prototype of the 2-piece implant from Straumann company that will be launched any time in next year. So you have a good primary stability with this kind of implant, very stable dental implant, and now just have to follow the preparation that you did. Now, because this is not a fully guided restoration, the company will have a fully guided implant. You know, when you have those 3 dots, it will accomplish final. But here you didn't have. So we take out the guide and you do the 2 extra millimeters freehand, just to check if everything is flattened with the bone. So here you have a very good primary stability. It means that the implant really engaged that buccal bone. You have a occlusal view of the implant. Now, What we are using, and because I told you that acrylic, zirconia, CAD-CAM has less inflammation, what you want to do here is not placing a regular flattened healing abutment. You're going to produce your healing abutment. You have the ability now to produce the best emergency profile in a CAD-CAM acrylic situation. Now you could do this on zirconia, but it's more expensive. What we are doing now is with clear acrylic. In a clear situation, we get a smooth, very smooth, highly polished healing abutment, which is already has the formation of the final rehabilitation because everything was planned previously. Now, when it comes to bone regeneration, we also know which type of bone regeneration would we have, how many grams are you going to use, because we already performed this surgery before and we saw how much bone regeneration we need. Now, dental assistant is already ready with this bone regeneration to go in, and it improves surgery because you're faster and you don't have to wait for anything to happen. Everything is previously set up. Now we have the bone and now we have the membrane, and because we also tried in a template, this is a piece of paper, we tried the template, we sterilized the template, and then at the day of the surgery we just have to cut the real membrane with the template and place the final membrane. So there's no time consuming on membrane preparation. So everything is ready. Either it's a resolvable membrane, if it's a titanium mesh, any type of membrane. You already have the template, you just have to cut it and place it. So you end up the surgery in a very quick way, in a very fast way, you suture everything up, and then you have a low inflammation protocol. Because of the studies that I show you, this situation will heal beautifully. Of course, this is a prototype. We only had the chance to try in the last months, so still waiting for final rehabilitation. I don't like to show cases without finishing job, but in this case it's not finished. But you can check it on the CBCT and on the tree-shape implant planning that your bone was beautifully placed on what you plan. So the zirconia implant is on the bone that you created, and the bone regeneration is also on the same place. Now, for finishing to resume, when it comes to zirconia as an implant alternative, in terms of osseointegration and soft tissue response, I think they're equal to titanium, if not better. Of course, we need more trials and more evidence on that. The things that it's a downside, it's a clear downside on the zirconium, is the long-term follow-ups, to see the mechanical complications that we have. But if the biological reason of the use of zirconia decreases the late failures after 10, 15 years, I think we have a viable alternative. If zirconia suffers the same problems as titanium in terms of periimplantitis in the late implant failures, then I think zirconia is not going to be an alternative. But we still have to see, because we don't have the long-term follow-ups. But one thing I know, in terms of patient acceptance, it's much better. Patient will accept better a zirconia implant over a titanium implant. So the take clinical message, because I don't like the term the take home message, because you take it home and you pull it on a drawer and you never open the drawer anymore. But if you take it to the clinic, then you're probably going to use on Monday. So the take clinical message that I say to you is that zirconia is an alternative, but be careful with some problems that zirconia may have, that we still don't know how do they behave in a long-term run. So I consider them as an alternative, but be careful. I mainly use 95% of my private practice is titanium, only about 5% is zirconia because of this. So to finish up and to wrap it up, I really like to thank Rui Pereira da Costa and João Borges for this magnificent initiative. I hope that I represent well Portuguese implantology in some way, but I want to thank to my dental assistant in particular, because she is there every day taking photos, taking cases, dealing with everything. And so a big thank to my dental assistant Liliana. Also the rest of the surgical team, the dental assistants Ricardo and Manuela, and obviously the member Artur from the oral surgery department that is always there with his technologies and improving every day. Of course, to my lovely wife, she's waving at me there. We are filming this. There's a complete crew over there waving, saying it's okay. I want to thank from the bottom of my heart, because a lot of time that I spent in the clinic I'm now spending at home with her. And of course, to my 3 kids, that do this every day, that make me be better every day. Because without them, I wouldn't think as big as I think. And I think that the take-home message, if you want, it's that think big, because it will take you to places that you never thought it would be. Buenos dias, buenas noches, good morning, adios, auf Wiedersehen, wherever you are. It was a pleasure for me. Thank you.